Hello everyone and welcome to today's webinar on prematurity. My name is Jessica Plunkett and I will be hosting today's webinar. The aims of today's webinar are to run through some of the facts and figures on premature births, explain what may cause a premature birth, and highlight some gestational developmental stages, work out the corrected age of a preterm infant, and explain the early gross motor development treatment and aims. If you have any other questions, please feel free to email us at the end of this webinar. I will now hand over and introduce you to our presenter, Nick Mant, a physiotherapist from Flying Start Children's Therapy.
Hello everybody. So before we get started with today's webinar, I just wanted to put a bit of a caveat out there that it's been developed for a mix of both parents and professionals. So some areas will obviously skirt over details and others will go into it more. So if you do need anything further clarifying towards the end, please, as Jessica said, just send us an email at the end. So moving on, first off we'll start with some facts and figures. So about 1 in every 150 births will be classed as premature. Survival rates of premature babies are gradually increasing, so from 1995 it was 40%, in 2006 it's 53%, and I did find some figures which said there's an 80% survival rate in 2011, but it wasn't from I didn't recognise where the facts were from, so hopefully those facts are right, but I'm not entirely sure where they were collected from, or how premature they were classing the babies. Certainly the later the baby is born, the increased chances of survival they have. So from 32 weeks, the chances are very, very high that the baby will survive without any problems. So although survival rates are increasing, the percentage of babies that survive with long-term conditions has actually remained unchanged. So this is a bit of a strange fact in that we're being able to make more babies survive, and they are surviving from a younger gestation, but just as many are ending up with the likes of cerebral palsy and long-term conditions like that. Some thoughts on this is that although more babies are surviving without these long-term conditions, we're actually making more babies that would previously have died survive, and they're the ones that are increasing the figures for the long-term conditions. So it's, you know, the less severe long-term conditions from days gone by are now unaffected, whereas the babies that would have died have taken up those numbers of the babies that would have previously had a long-term condition. Obviously, it raises some very difficult ethical dilemmas for the senior medical staff when saving a baby's life. So currently we will, consultants in the UK, I'm not sure what it is in other nations, but they will save babies from 23 weeks gestation, and their parents will give them the option to give full medical intervention. We have relatively good survival rates for those children. But to put that in perspective, you can, in the UK, you can still have abortions up to 24 weeks gestation. So, you know, there's the ethical dilemmas for you on whether you should make any earlier babies survive, and the long-term conditions of these babies. So it is quite, and parents are having to make these decisions in very, very stressful times of their lives. You know, when they're not expecting to have a baby, here it comes. They've been preparing for this, you know, life-changing event, and then suddenly it all goes very, very differently to how they've been planning. So moving on to what we actually class as a preterm baby. Actually, any baby born before 37 weeks is classed as preterm, or premature, sorry. But the World Health Organization, and this is how we divide it up in the UK as well, so the World Health Organization class any baby born between 27 and 32 weeks as moderate to late preterm. Then we've got the very preterm of 28 to 32, and extremely premature, which is less than 28 weeks gestation, and the less than 28 weeks gestation would be visiting the most specialist neonatal unit that you can visit. So there's 3 different levels of neonatal unit, which I'm sure we'll get into later. Where I currently work in Yorkshire, we have high-risk baby clinics. So the high-risk baby is born, any baby born before 31 weeks gestation and weighing less than 1,250 grams, or any baby with altered head scans, and I'll talk about head scans in a bit. And then you as neonatal unit, the therapy input depends on your location. Our local criteria for therapists to get involved with a baby on the actual unit rather than just once they've been discharged into the community is born before 29 weeks, 29 weeks or before, with altered head scans or a diagnosed syndrome, or with any baby with which staff are concerned about, so if they just want us to cast our eye over. And that, as I say, varies greatly different regions. Where we are, it's a physiotherapist that gets involved. In other areas, it's occupational therapists, and some areas don't have any, and they wait until they're in the community before those professionals get involved. So it does vary quite greatly. What causes a baby to be born prematurely? In many cases, it's not known. So in about 40% of premature babies, there's no health risk. There's no risk factor that might have caused it. So it's really, generally, it's an unknown reason. But in 60%, there is some of these risk factors, and this isn't all of the risk factors, these are just common ones that I know about. So multiple births, so twins or triplets or quadruplets, will likely be born early because of space running out in the womb. Previous premature births, if mums have had previous births, they are at risk of having a premature birth, but that's not to say that they definitely will. Some chronic conditions such as diabetes or high blood pressure, and certainly gestational diabetes, may cause your baby to be induced early or born early, because babies can be a lot larger in those instances. Smoking is a very big one for causing premature birth. We know that parent or mothers who smoke or use recreational drugs during gestation will, or during pregnancy, will have, or are at a very high risk of having a baby born prematurely. Mothers with very poor nutrition, being significantly over or underweight before pregnancy as well, can link in with prematurity. Infections during pregnancy, I keep saying prematurity instead of pregnancy. Infections during pregnancy will increase the chances of a premature birth, but it is not all infections, so mothers shouldn't be worried if they've got a cough or a cold or a viral chest infection or something like that, because that's not going to have any effect. But infections that might link in or might affect the placenta or urinary tract may cause a premature birth, and obviously physical injury and trauma during gestation might cause the body to go into labour. Next is data collection, I believe. Yeah, so because prematurity is a worldwide issue, and it does cause significant long-term health impacts. Most countries will have a form of collecting data on premature rates and survival rates and care levels and things like that. In the UK, we use a system called Badger to collect the information, and that will follow babies right up until at least, if they're discharged before, then obviously they will be discharged, and all data will be collected up until they're discharged, but it's at least until they're 2 unless discharged before, and that includes, and that will include the levels of care that they received whilst on the neonatal unit, and the long-term outcomes of a 2-year-old assessment. A good lot of information is available on the Premature website. When they did 2 studies, the first back in 1995 of children that had been on neonatal units, they then followed those same children up at the age of 16 to see what their health issues were, or cognitive levels were, and things like that. They redid their 1995 study in 2006 as well with large numbers of children, and they are also going to repeat that. So there's loads of information available at epicure.ac.uk. It's a really good website. Head scans are routinely done for, I couldn't find where, when they're actually routinely done, at what gestation, but I think it's pre-35 weeks, but I'm not sure. Sorry, pre-32 weeks, but I'm not sure. And in the first instance, what will usually be done is an ultrasound scan, so a USS, and it's completed through the anterior fontanelle, and they'll be able to see if there's any bleeds or any issues in there. If they do have problems, or if they find anything wrong, they often will then do a CT scan. And in this stage, when babies do stay still, the baby is not needed to be put to sleep to have that. MRIs are if their MRIs are done, they're usually done much later to get a more detailed picture. So maybe when the baby's 2, and they will put baby to sleep with analgesia under that. So obviously, with the risks of putting baby to sleep, they wouldn't want to do that unless it's needed. And the abbreviations that you might see with head scans are SEH, which is subependymal hemorrhage, which is, I believe, grade 1 or 2, but I'm not sure. It's certainly the less severe of the head scans, and subependymal is the region of the brain. Hemorrhage means bleed. So intraventricular hemorrhage is graded 1 to 5. Grades 1 and 2 are very common and relatively mild, and these are due to the blood vessels around the ventricles in the brain, which is, if you look at a scan of a brain, this is for the people that might be in a position to do that, the ventricles are the bit which looks like butterfly wings, and there are very fine blood vessels that go around those ventricles, and in the early stages of life they're very, very delicate, so during the early stages of the neonate period they can bleed, and the grades 1 and 2 are when they're just bleeding out of the blood vessels, and it's generally speaking the brain will reabsorb that blood and it will heal and be absolutely fine, and then grades 3 to 5 are when they're graded depending on how much the blood and where the blood actually penetrates, so whether it goes further into the brain or actually goes into the ventricles, and a grade 5 being fairly severe. Generally speaking, we as therapists don't necessarily get involved with grades 1 and 2 unless we're seeing physical presentations of that with altered movements. 3 and 5 we will get involved for at least an assessment. Generally speaking, grade 5s will have some sort of long-term condition, but I know of several instances of children that I have treated which had a grade 5 intraventricular hemorrhage and have actually come out without any, or by the time I discharged them physically, they had no problems. So we can see these pictures and we can know all the literature, but children do not always conform. They're very much their own beasts and will do whatever the hell they want. Then you have a hypoxic ischemic encephalopathy, or an HIE, graded 1 to 3, with 3 being very severe. These are generally events that have occurred immediately after or during labour, and it's as a result of lack of oxygen flow to parts of the brain and lead that part of the brain then dying. The other thing which I haven't put in there is PVL, which is periventricular leukomalacia, which is little cysts that can cause in the brain due to bits of death in the brain. Those cysts then expand and can kill larger areas of the brain, and they can be quite scattered. Generally speaking, children with periventricular leukomalacia will have a long-term condition, and that is generally speaking a more severe, along with a hypoxic ischemic encephalopathy and grade 4 and 5s intraventricular hemorrhage, are a severe finding on head scan. But to reassure parents out there, we can say this in theory, and children will dumbfound us and have a PVL that they then actually perform physically well with. Moving on. This is for those that might receive communications from neonate units, discharge letters maybe. Parents might see those and there'll be lots of jargon written on there. So NNU is obviously neonatal unit. NICU or ICU is the intensive part of that. Not all neonatal units will have an intensive care aspect to them or necessarily a high dependency part. It depends on what level unit they are. If a baby is born, for example, 28 weeks before, they will go to an intensive care unit, and then when they maybe get to 32 weeks and they're feeding a bit better and their obs are more stable, then they'll get transferred to a more local centre where their care can be carried on standard, a special care baby unit or neonatal unit. That's what's not on there, special care baby unit, which is SCBU. CLD, because of the very late development of the lungs when in gestation, a lot of premature babies do have issues with their lungs, and this can present in chronic lung disease, which can resolve but often leaves long-term conditions such as asthma. ROP is retinopathy of prematurity. So similar to the very delicate blood vessels around the ventricles in the brain, there's also very delicate blood vessels at the back of the retinas, which can become damaged and leave retinopathy of prematurity. Hospitals here have specific clinics, RAP clinics, and babies can get laser treatment to improve this. Other eye conditions, you can get more longer-term conditions with the eyes in prematurity, which will leave visual problems in the long term. Then you've got NEC, which is necrotizing enterocolitis. I've had to practice all of these to make sure I say them right. And that's a damage to the neonatal lining of their gut, and if that becomes infected, it can lead to large areas of the gut needing to be excised, so cut out. So it can be treated conservatively, where they get monitored and given antibiotics, or more drastically with actual removal of parts of the gut. Then you've got a PDA, which is a patent ductus arteriosus, which is an opening between the aorta and the pulmonary artery, which, for those medically minded, means that oxygenated blood coming back from the pulmonary vein into the heart and into the aorta, instead of being pumped from the aorta around the body, goes back to the lungs, where it's obviously it should be going around the body, and it means that the heart and the lungs have to work extra hard to make sure enough oxygenated blood is getting around the body, so it can lead to breathlessness and high work of breathing and things like that. And that sometimes needs to be rectified with surgery. Other times it's just left and it will close by itself. We go on to high risk. So previously I mentioned that we have high risk clinics, and we class high risk as what are they at high risk of. So a caveat here, obviously not all babies experience these problems, and although we can generally say that the earlier the baby is born, the more at risk they are, it's not to say that all babies born at 23 weeks will have these problems. It's just simply these are the things that medics and other healthcare professionals around the baby will be aware of in order to minimize their risks or to minimize their impacts. So in the early period, so whilst on the neonatal unit, what are they looking for? There's obviously the breathing problems, so the undeveloped lungs. If a baby is born early, they haven't got what's called a surfactant release into their lungs, and this is sort of a fluid which helps the lungs to inflate and move from exhalation to inhalation, and that will be something that the medics will actually put into the child's lungs, or a fake version of it, when they're born, to try and help that. Babies will often need oxygen therapy and ventilation, and they might have chronic lung disease. Some babies go home from the neonatal unit on a certain level of oxygen. For the medical-minded folk out there, if you're aware of oxygen therapy on wards or anywhere really, it's on adults it's often at 2 litres whilst they're at home, sometimes more. On babies it can be as little as 0.02 of a litre that they're on all the time, and that will maintain their blood oxygen at above 98%. But you take them off that 0.02 and it will drop quickly, or may drop quickly. So it's very, very small amounts of oxygen that these babies need, but they do really need it sometimes. Obviously they're at risk of heart problems because the hearts are undeveloped as well, and that PDA can lead to shortness of breath and increased work of breathing. Brain damage is a big one, and this is the one which parents and professionals will keep an eye out for, or certainly physiotherapists. We will keep our eye on signs of that, and there are tests and things that we do that indicate brain damage, but a baby's brain is very, very delicate, and that's why their head scans are done routinely and sometimes repeated, because damage to the brain might not show up on their early scans and it might appear later on. So that's why sometimes they're repeated at 2, even if their early scans aren't showing a problem. They have babies can have thermoregulation difficulties, so actually maintaining their own body fat, because maintaining their own body heat, because body fat is laid down very late in gestation. So neonatal units will be very warm, and you will see babies on there with multiple layers of clothes and multiple layers of blankets and things, which obviously when a baby goes home, you're told to, typically developing or a term baby, you're told to be careful of overheating children, but because of their difficulty regulating their own heat, it's very different on the unit. Then there's the gastrointestinal problems, so that's the neck, and that's because of very delicate bowel lining. Interestingly, if parents are managed to express breast milk, neonate babies or premature babies who are fed breast milk are at lower risk of receiving neck if they have expressed breast milk. But obviously that doesn't always happen with or can't always happen with babies, and that's also why neonatal units will try and give babies express breast milk from donated milk. There's obviously infection problems. The immune systems of these babies is undeveloped as well, so there's a high risk of infections and things like that. So the hospital neonatal units and things will be very, very hot on infection prevention and control, with wearing various clothing, and there's all these sorts of rules that when you go onto a unit you have to be aware of, and parents will be told about. So parents that go onto these units spend a lot of time on that. Babies can be on there for weeks, and you'll see them coming in and gelling their hands and rolling their sleeves up and not wearing any jewelry and things like that. So they do as much as they can to prevent infections. Feeding problems are difficult, so if a baby's born pre-32 weeks, they wouldn't have even developed their suck reflex. So how are they going to feed if they can't even suck? Some will manage it. They're given, some are fed with a cup and things, but largely it's through a tube in their nose that will give them the nutrition they need in the early stages. And then there's blood problems like anemia and jaundice. So you will go onto the units and see babies under phototherapy. I'm not sure if anyone's aware of that. It's like UV light placed on the baby to stop jaundice. And in days gone by, severe jaundice can lead to damage in the brain because of bilirubin laying down. I think it's the bilirubin lays down bits within the peduncle, something like that, in the brain, and that's largely gone within developed countries because of phototherapy. So the UV light that helps break down the bilirubin in the blood, or the extra iron in the blood, however it works, stops that. But in less developed countries, that's still a problem because of the lack of identification of jaundice and the lack of phototherapy. So that's how the presentation of cerebral palsy might vary between countries because of different treatments in the neonatal period. Long-term complications for these babies. The chronic health issues link back to the early heart, lung, and feeding problems. So whether it be problems with the gut, or asthma, or all these sorts of things, they're the chronic health issues that we would talk about. The cerebral palsy is probably the biggest one that parents will be aware of because it's a very well-known condition, and there is a very high risk of premature babies developing it. So that's one of the biggies. There is studies that link, and I think the Epicure was one of them, that linked more preterm babies with lower IQs. Again, it's not with all, so I don't want parents to be too concerned, but it's just a link that the earlier babies do have lower IQ. Then there's the visual and hearing problems and coordination problems as well. So some babies that develop and become very physically active struggle. And so what was used to be known as dyspraxia, some develop developmental coordination disorder. So some key gestational development. At 23 weeks, components of the eye are all present, though delicate, so that's why retinopathy and prematurity can still occur. Palmar grasp and startle response are present. So startle response is those that you see babies do when they get a shock and their arms shoot out to the side. And the palmar grasp is that which, there's the old story, I don't believe it for a second, that if you place a newborn baby's hands on a washing line, the palmar grasp reflex is supposedly strong enough for them to hold on to the washing line. I wouldn't advise testing it, but that's when it starts to develop. And these are things that assessments on the unit will look at to see how developed the baby's neurology or central nervous system is, to see whether they're developing these responses and to see whether they're persisting for too long or not developing at all. Tone, so muscle tone, we all have muscle tone, and you hear people that go to the gym saying they're toning up, and it's basically the resting level of a muscle, so how active a muscle is at rest. It doesn't really begin to develop in a preterm baby until 23 weeks, because that's when they start to kick, and this is when mums may feel them, or pregnant ladies saying that they can feel baby kicking, and that's when tone's developing in the legs, because if you think they're coming active, and the womb is a great gym, it's where babies really develop their early strength and their early positions, and the first one is kicking. So tone generally develops in the legs and moves up, so that would be another aspect to think about if you're on the unit and doing an assessment. The legs generally tone begins in the legs and works its way up the legs, starts in hands, works its way up the arms, and develops last in the trunk. So premature babies tend to be described as floppy. At 26 weeks, baby starts to inhale and exhale amniotic fluid, and if that's practicing the breathing itself, then think about the babies that are born before that if they've not had that time to practice the breathing actual routine in the womb, then that's a big thing to struggle with later on. 31 weeks, so very late on, body fat begins to rapidly increase. So this is the bit where pregnant ladies generally grow quite a lot in the last period, because it's maybe not growing lengthways but growing widthways, and when they start to get a bit of that early chunk, so that's why they really struggle with that temperature, because they don't have the body fat before then. Rhythmic breathing occurs, so they're really getting the hang of they need to breathe in and out, but the lungs are still not fully mature. It's very late on that the lungs actually fully mature. An increasing connection with the part of the brain that mediates sensory input. So babies that are born early struggle with lights and sounds and touch, because their body, the part of the brain that actually controls that, isn't necessarily fully developed. So you might go onto the unit, do something with a baby, some sort of an assessment, and then they would actually not really realise that it's been done until much later, and so they might actually start crying sort of 10 minutes later when they've finally processed that this has happened to them and they didn't like it. So that needs to be borne in mind as well. Bones now fully developed, or well, they're fully there, they're just very soft. So if you think the baby's before that, if the bones aren't even fully developed. 32 weeks of suck response allows baby to take from the bottle or breast, so this will really link to the early feeding difficulties. But the ability to suck, or the suck response, isn't fully developed until 36 weeks, so it's quite late on for that as well. So beyond the 32 weeks, body fat is continually increasing, but the central nervous system isn't developed until at least 34 weeks. And beyond. The lungs and brain are fully mature at 37 weeks, so that's very, very late on in the gestation that lungs are developed. Neonatal environment compared to the womb. Neonatal units will do their best to match the environment of the womb and to make it the most welcoming environment possible, but it isn't the womb. They generally are brighter. They will close curtains during the day and try and be a bit dimmer, but it's definitely brighter than being inside a womb. There is loud sudden noises, whether it be someone coughing or the bonging of a monitor going off. The muffled noises in the womb, as best as I could find out, is about 72 decibels. A running tap is about 55. General conversation is around 60. Hushed conversation is around 60. So you can see why it might be hard for babies to process loud noises. Generally speaking, if you go onto a unit, they are very subdued places, and it'll be by the nurse's station away from the babies that normal louder conversation takes place. The difficulty being on something like a doctor's ward round, and doctors that are new to the unit might not realise, and they might put the OBS chart on top of a incubator, and that sound obviously for the baby is very, very loud, so they will very quickly get told off by the nurse in charge for doing that, or parents that come in might knock on the incubator to get attention of baby. That's obviously a very bad idea as well. Neonatal units are open and very spacious for babies. If you left them by themselves, they'd be all spread out, but a womb, they're very folded up and small. Neonates is dry, and the womb is wet, and this is a big thing because as it's written two down, it's the skin can develop more and things like that, but it's also the actual support that water provides, the amniotic fluid. If you're laying in a pool, you're supported, you're not dependent on gravity. You can lay there all nice and relaxed, whereas if you're laid on the side of the pool, you're squished to the pool itself. On the neonatal unit, as I said, they generally try to keep warm, but they will have a varied temperature. If they're in an incubator, it's very, very well controlled, but when they get into a cot, it will vary more. Assessments need to take place, tests need to happen. That means stripping baby and getting baby cold. Certainly when us as therapists do our tests, we have to do it with baby just in their baby grows, so they might get a little bit colder then. But that is much later in baby's gestation. We wouldn't get involved until they're much more stable. The neonatal unit is very intrusive. The tests are happening, but babies are left alone in the womb. They're left to develop. But on neonatal units, they're taking bloods, they have monitors stuck to their skins, of all this sorts of things. They will try, or units will try to cluster assessments so that it's not a constant thing, so the baby can have however many hours. If they're unstable, it would be 6 hours between assessments and things, so that they're left alone as much as possible. And units will do that. They will leave a baby alone for as long as they can. It's not about holding baby and doing that support that you might think of a newborn. It's about letting them develop, because their central nervous system is not developed, and you need to let that happen. On to correcting age then. So it's important for this to be done, and it's important for parents to be aware of it. Parents will get sick of explaining this to acquaintances, because friends will know what's happened. Friends and family will largely know that baby's small because they're premature, that they're a bit delayed with their development because they're premature. But we correct the age because the development that would be happening for that baby, the brain, their muscles, their skeleton, has still got to happen despite the fact that they've been born. It's not like they start from birthday. The development is still the same. So what we do is we take their actual age and we subtract the number of weeks they are premature. So if they were born 4 weeks early, then we correct that age so that when they're 2 months old, we would correct it to 1 month old. And that's how you correct a baby's age. If they're very, very premature, babies will generally be small. They will be corrected for 3-4 months that they've got to correct. So for the first 6 months of their life, they might have someone come up to them and say, "Oh, how old's your baby?" 6 months. Aren't they small? Yes, well, they were born premature. Oh, are they sitting yet? Well, no, not yet. They're not able to because they were premature. And then because you've got to treat that baby, if they're 4 months premature, as a 2-month-old, and you wouldn't even expect a 2-month-old to be rolling. So it would be very unfair to expect that baby to be sitting, to be rolling, to be doing as much as a 6-month-old would. So what parents, or a lot of the parents that I know, have done, when someone that they aren't as close to asks baby's age, they'll say, "Oh, they're 2 months old," just simply to avoid having that conversation again and again and again. We correct a baby's age up until they're 2 years old. That's the general consensus of when they have had enough time to catch up. That's obviously in the absence of other long-term conditions. So if a child has a diagnosis of CP, you wouldn't necessarily expect them to, CP, cerebral palsy, then you wouldn't necessarily expect them to catch up at the age of 2 because they have a condition. But if in the absence of conditions, you generally expect them to catch up until they're 2. This isn't always the case, but that's the best we've got to work with. Other areas, I believe this is in the States because it was new to me, but they take the number of weeks premature, they multiply it by 10, and that's the number of weeks you need to correct for. So as I said there, 5 weeks early is 50 weeks, so you would only correct until that baby was about 1 year old. It's 2 weeks short of a year, isn't it? So it's about that. I like up until they're 2 because I think babies have had a really rocky and unfair start to their life being on the unit. So I think give them as best chance as you can to catch up. I do to relieve maybe any concern of parents that might be listening. Although we do correct for that, so that is their corrected age, often babies will be more delayed than that because that is correcting it to the age of a baby that is born at gestation, and premature babies aren't born at gestation, so they haven't had as good a development period for however premature they are. For those 4, 6, 10 weeks, they haven't had the best place to develop. So if you compare that to a term baby, if they're 6 months old and they've just been left in a corner, that baby is not going to be doing as much as a 6-month-old who's had a parent that's gone to every baby class going and has stimulated that baby for 6 months. That's how I figure of the correcting. Is it's not fair to expect the baby to be performing bang on their corrected age. And there are assessments that people can do to see how well a baby's doing and to see what areas they might be underperforming in, and give them activities or advice on how to catch up in those areas. So on to early gross motor development treatment and aims. The first thing, and if there is the other webinars for PlayPat to go, which goes a little bit more in depth in early positions of play and things like that, but specific to prematurity, the first thing that it's important to understand that premature babies are missing is this physiological flexion. So baby, that's a good picture of what physiological flexion is. It's that curled up position, and you'll see if babies, term babies, you'll see them in that almost that position. They might get their legs straight down, but if you lay them on their tummy, they're like that as well. They just turn their head to the side, or if you lay them on the side, they're still flexed. And it's almost that the muscles, the flexor muscles, so the muscles that bend your arms and bend your legs, are tight, really, but it provides the body with a lot of support, and so it allows the head to be in the middle. It allows them to be stable and to develop where their middle is. But preterm babies won't necessarily have this. That baby is like how a preterm baby would lay, with like a squished frog type position. So the early movements, for a start, a preterm baby might be floppy in the trunk, so it might be really hard for them to actually kick and move their arms. A term baby would be, their early movements would be those jerky stretches, so they'd stretch their arms out and they'd stretch their legs out, and that would then almost get rid of physiological flexion. It sort of nullifies it, I guess. And so they'll go from this nice stable position where they can develop midline and develop where their center of their body is. Then they'll stretch out and get themselves nice and loose and allow them to move more, but then that stability goes, so the head might flop to the side, but they've already developed the strength in their arms and their legs to move a little bit, so they'll then be able to bring their head back to the middle. Not always. Some, term babies, if they're left on their back, they'll still turn their head to the side, but certainly with the neonates, their floppy trunks and things, they really will struggle, and their head will just turn to one side and be stuck there because gravity is, I was going to swear then, gravity is annoying, and is hard on these babies. So the units, knowing this, that their babies are lacking physiological flexion, will put them into nests or in nice supporting roles, so that it tries to bring their arms and their shoulders away from the floor, their arms together, their shoulders away from the floor, and their knees more closer together, and their hips off the floor, so just the shoulder girdles away. What's our early aim? Priority is developing that midline awareness, so with their head in the middle and able to look left and right, and just to know that where their middle is. What they like, term babies are very frequently develop a head turn preference, and it's very common. But the unfair advantage that term babies have is that they generally have the strength to turn the other way, and if you're active with your baby, then they will correct that themselves. Often correct themselves, not always, and whereas the preterm babies, if they're left turned to one side, they will get a flattening of one side of their head. That has no impact. The flattening of the head, or plagioccephaly, has no impact on neurological function or brain function at all, because brains are very squishy as our heads in the start, so they just simply adopt the shape. So it's not a neurological concern, it's more of a cosmetic one, but it's not pleasant. And if babies do get a head turn preference, then what they can do, or early, as they're developing neurologically, is they'll be more aware of one side, so they'll be more aware of their right hand and right leg, for example, and then they'll forget that their left one's there, because in the early stages they don't even know they've got hands, they don't know they've got legs really. So if they're only looking at one of them, how are they going to develop that left one? So in all positions we want to support baby to become more aware of their midline. Initially we'd want them to work on key positions, then progress to movement between them. So these early positions are, put simply, laying on their back, laying on their side, laying on their tummy, and advice should be given to parents to vary these positions so that it gives babies a chance to develop. The other thing which is often forgotten actually is that you might alter some general activities for preterm babies compared to term, or delay them. So baby massage is a very common class for around here, I know, and it is really, really good for both preterm and term babies, but a term baby that attends baby massage, they will be trying to work away from that physiological flexion, away from the middle, and developing sort of stretching out, whereas that's the last thing you want to do for the preterm baby in the early stages. You want them to be bringing them back in. So I would ask your local therapists or professionals on how to amend that. It might simply be a case of going to those classes and attending the same classes as the other babies, but waiting until your baby has developed that midline. So if you correct the age, you might be attending at the same time rather than going on chronological age. So you wouldn't attend when you're 3 months, you'd attend when you're 6 months because you were 3 months early. Positions to play. We've got back lying, side lying and tummy time, as I said, and they each have their own advantage and each have their own things that they're developing, but they all link very, very, very closely, basically. And the real key is varying the positions, because often we see that babies have been left on their back because they're happiest there, they can see the world, it's easy, but if they haven't been provided the support at their shoulders or at their hips, then they'll be stuck and they can't move, and they will, especially neonatal babies, preterm babies, they will develop a head shape issue. So whether it's plagioccephaly, which is flattening of one side of the head, or brachycephaly, which is flattening at the back of the head. Now we see this quite a lot, and it seems to be, it's very difficult and a very common problem for neonate babies, because the head itself is very soft and malleable, so it develops quickly and it takes a while to go away. But the anterior fontanelle, so that hole at the top of the baby's head, or gap between the skull, doesn't really close until 18 to 24 months, largely. So you've got plenty of time for it to be improved, and the only way that it would improve is with more activity and varying positions. So lots of tummy time, lots of sideline to the other way, and lots of activity and support to help babies look left and right, to bring their arms to the middle, to be aware of things above them or below them, and putting weight through their elbows and all sorts. So supine, so back lying, what's it good for? Early communication, and with support underneath the shoulders and the hips, it can develop a nice midline for baby, and it could develop anti-gravity movements. It's a very hard position for babies to move in the early stages, because they've got to lift first their shoulder, then their arm away from the surface, from the floor, and their very heavy limbs, and also the head. So you might see baby laying on the head, but they really wouldn't be able to lift the head off the surface, so maybe a little pillow or a little support under there to help them look down at their tummy to bring their hands to the middle. Side lying is great because it eliminates gravity from having to bring their hands together. Gravity makes them bring their hands to the middle, and it also is very easy for baby to look at their hands and develop more of awareness of their hands, and also awareness of midline. It also means that the hips and the legs are brought together, so they're not in that frog leg position that we showed in the picture, in the drawing earlier. Tummy time is the very, very important one. You'll hear, if you're under physiotherapy or any therapy really, you'll hear us rambling on about tummy time. It is hugely important at allowing babies to develop, especially with SIDS guidelines for sleep, which is the Sudden Infant Death Syndrome's guidelines. So putting babies on their back to sleep, which is very important. Do continue to put your baby on their back to sleep, but when the flip side of that is that parents are often more concerned about putting their babies on their tummy. We don't want that. To play, when you're there, you put your baby on their tummy to play. And early on, when babies are really little, which they will be coming off in the neonatal unit, it's not on their tummy on the floor, it's laying on parents' chest or in their arms, just so they get used to being on their tummy. So mine really liked being with his head looking down by the crook of my elbow, and his chest supported on my arm or over my shoulder was a common one. When babies are happy in those sorts of positions, we can work more on rolling and moving between those positions, but we will often work on those moving between positions even before they're happy. And as I say, for more information on the earlier positions, you can find them in the playback webinars, which are relatively good. That's it. So thank you for listening, and there's my email if anybody would like to ask any further questions, either that one or contact Firefly.
Thank you so much, Nick. We just have a few questions for you to answer. So what types of therapy would my child receive in NNU?
As I said before, it depends on the region and nation. I have no idea what other countries do. For us, it's if you have a physio or an occupational therapist that visits the unit, it will be mainly an assessment that they will be doing. They will also give advice for discharge when home on how to play with baby, but largely it's seen later on in their gestation. So when they've been, if you work out they might be 4 weeks old, but their gestation will be 36 weeks, for example. That's when we would be getting involved to do assessments of. There are some assessments which can quite accurately predict if a baby has neurological impairment. So by looking at movement, comparing, excuse me, left side of their body to the right side of their body, arms to the legs, how they flex and how they extend, so bending in the middle and throwing their arms back and things like that. You can pair all those things to predict whether there's a neurological deficit. So, as I said, largely it's an assessment tool. Also, it does depend on what level of care. So some units don't have any. The 3 levels of care, there's the special care baby unit, which is level 1, so that's the very basic for babies that need constant monitoring, maybe additional oxygen and tube feeding, some phototherapy, but not necessarily any connections to baby, so wouldn't need ventilation or things like that. So you've got level 2, which is your local neonatal unit, which is where I would have a little bit of work in my local neonatal unit, and that's for short-term intensive care with apneic attacks. So they're short periods where a baby might stop breathing. They would restart by themselves, but they obviously need monitoring to make sure that they're restarting. And they can have a little bit of ventilatory support, so CPAP, which is where air is continuously blown into babies' lungs to try and splint airways open and keep them nicely inflated. Then there's level 3, which is the intensive care, so that's the full support. Yeah, so they're 3 different levels. So I've gone off the topic again. Did I answer the question?
No, yeah, that's great. Perfect. Thank you so much. Another question is, you have mentioned that the survival rate of a premature baby has increased in the last few years. How has this happened?
So it's differing reasons. Partly, so the survival rates is the neonatal period, and I believe and it's after discharge as well. So is it 28 days after discharge from the unit that it's included? So part of that might be things like SIDS guidelines. So what I talked about, parents are advised about sleeping on their back and having the foot to the base of the cot and not having anything in the cot and not smoking around the baby and all these sorts of guidelines. That will have one big impact. Interestingly, on the sleeping on the back front, on the unit, babies on neonatal units, babies will be sleeping on their front, and that's something that often is quite confusing for parents, because they will go from being well looked after and sleeping on their front to then laying on their back and being told do not do it. But it's because they're or do not do sleeping on the front. It's because they're monitored so closely when they're laid on the front that it's not a risk. If they're starting to lower blood oxygen, then they will quickly be sorted out. So yeah, the SIDS guidelines will be one. It will be also better identification of any problems when babies are struggling when still inside mum. So if placenta is failing, they might induce sooner rather than letting it go to natural delivery and then having an issue then. What else? The better medical care whilst on the neonatal units. I mean, medication's always improving. Our knowledge of the brain and how to treat these babies is always improving, so that's obviously a big thing. But then also one of the largest medical changes for babies is head cooling. So actually lowering a baby's blood temperature, lowering a baby's core temperature to 33 degrees C, I think it is, and keeping it there. And this is for more term babies, so babies that haven't got those thermoregulation problems, so I think it's 36 weeks and after, but don't quote me on that one, that would then, if they've had an incident during labour that might have caused brain injury, they will be sent for and basically made hypothermic so that less blood is sent to the brain, so that less damage actually occurs, and that's had a huge impact on outcomes for babies.
That's so interesting. Okay, and lastly, you touched on this for sure, but why is it important to vary the positions I place my child in?
So babies, especially neonate babies who have that floppy trunk, won't be able to get themselves in other positions. We will often, even term babies that might come to see us later on, is because they've been laid on their back a lot, and it's not necessarily and it's not deliberate, it's not laziness on the parents' part, it's often that baby liked being in that position, so they've just been left on their back, and they use different muscles in different positions. So they bring their hands to the middle, they get stability at their shoulders and at their hips if they're placed on their tummies, and they can't get into these positions themselves, so we must vary it, and we use different muscles, we become aware of our bodies differently. So if babies never laid on their side, and children who have diplegic cerebral palsy, which so affecting both of their lower limbs often didn't lay on their side very much because they're not very good at rolling, and they wouldn't be as aware of their sides. So they can't move laterally, so leaning from left to right. So that's walking, you have to move from left to right to walk. So if you're not aware of your sides, or then how would you develop those things? How would you develop to crawl if you've not been on your side to know that, oh, my arm's there, I can use that, I can put weight through that. So yeah, it's just it's how babies develop, is being put in different positions because they can't do it themselves.
That's great. Thank you so much. And thank you all for listening. I hope you've enjoyed this presentation. And if you have any further questions, please feel free to contact Nick via his email address. And be sure to check the Firefly website for our upcoming webinar next month.